Hello,
This
everyone.
meeting is being recorded.
My name is George Isham, and as chair of this study, I would like to welcome everyone to the first meeting for the review of relevant literature regarding adverse events associated with vaccines. This study is sponsored by the Health Resources and Services Administration and the Centers for Disease Control and Prevention. Today, our sponsors will formally present their charge to the committee. I want to note that this is an open, on-the-record session. Interested individuals and members of the press have been invited to attend as observers. This is not, however, a news conference, and we will not be entertaining questions from the floor. I would also like to remind everyone that this is an information gathering session. That is, the committee is in the process of assembling materials that it will examine and discuss while developing its findings and conclusions. Therefore, I ask everyone here today to be extremely mindful of the fact that the committee has made no conclusions, and it would be a mistake for anyone to leave here thinking otherwise. Comments made by individuals, including committee members, should not be interpreted as positions of the committee or of the National Academies. In addition, committee members typically ask probing questions in these information gathering sessions that may not be indicative of their personal views. The committee will deliberate thoroughly before writing its draft report. Moreover, once the draft report is written, it must go through a rigorous review by experts who are anonymous to this committee, and the committee then must respond to this review with appropriate revisions that adequately satisfy the National Academies Report Review Committee and the National Academy of Sciences President before it is considered an official report of the National Academies. Now I'd like to ask the committee members to introduce themselves, giving their names and current affiliations. Brief bios of all committee members are available online at the activity website. So I'll start. I'm George Isham, Senior Fellow at the Health Partners Institute in Bloomington, Minnesota. Dr. Bass?
I'm Ann Bass. I'm a rheumatologist at the Hospital for Special Surgery and Weill Cornell Medicine in New York.
Dr. Fairweather?
She hasn't joined just yet.
Okay. Dr. Floyd?
Hi, I'm James Floyd. I'm a general internist and epidemiologist. I'm currently Associate Professor of Medicine and Epidemiology at the University of Washington.
Dr. Hegedus?
I am Eric Hegedus, and I'm a professor in the School of Medicine at Tufts University.
Dr. John?
Andy John, Professor of Pediatrics at Indiana University.
Dr. Kuhn?
He'll be joining us in a little bit.
Okay. Dr. Mayo Wilson?
I am Evan Mayo Wilson. I'm an Associate Professor of Epidemiology in the UNC Gillings School of Global Public Health.
Dr. Ortel?
Hi, I'm Tom Ortel. I'm Chief of Hematology and Professor of Medicine at Duke University Medical Center.
Dr. Reed?
Hi, I'm Nicholas Reed. I'm an assistant professor in the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health with a joint appointment in otolaryngology audiology at the Johns Hopkins School of Medicine.
Dr. Strigakis?
Professor of Pharmacy and Public Health, University of Washington. Thank you.
Dr. Toledano?
He will join us later.
Okay. Dr. Wallace?
Hi, I'm Bob Wallace. I'm an emeritus professor of epidemiology and internal medicine at the University of Iowa.
Dr. Zerbo?
Hussein Zerbo, and I'm a research scientist at the Kaiser Permanente Northern California Vaccine Study Center.
Okay, thank you all. And I don't see the ones that were not earlier on when I asked, so we'll move right along here. At this point, I'd like to welcome Dr. Reed Grimes. Dr. Grimes is the Director of the Division of Injury Compensation Programs at the Health Resources and Services Administration. I'd also like to welcome Dr. Tom Shimabukuro, Director of the Immunization Safety Office at the Centers for Disease Control and Prevention. First, my understanding is Dr. Grimes will make a presentation. Dr. Shimabukuro will add some comments, and then the committee will have the opportunity to ask follow-up and clarifying questions. And when we get to that point, I'd asked that the committee use the raise hand function so we can recognize people in order and in an orderly fashion. So I'm very much looking forward to this presentation. It's very important for us to have this conversation. So I'll turn it over to you, Dr. Grimes. Welcome.
Thank you very much for that introduction. I will go ahead and share my screen. All right, is everybody seeing my screen? Excellent. All right. So as a part of the charge to the committee to review the relevant literature regarding adverse events associated with vaccines, we wanted to provide an overview of our injury compensation programs within the Health Resources and Services Administration, or HRSA. Today, we'll be talking about the National Vaccine Injury Compensation Program, or as we call it, the VICP. We'll also be talking about the Public Readiness and Emergency Preparedness Act, or the PrEP Act as we call it, and the Countermeasures Injury Compensation Program, or the CICP, and then review the statement of task for the committee before we turn it over to Dr. Shimabukuro for his comments. So the VICP was established in 1988, and it was born out of the National Childhood Vaccine Injury Act of 1986. The purpose of the VICP is to ensure that individuals injured by certain vaccines are provided with fair and efficient compensation, and to ensure a stable vaccine supply by limiting liability for vaccine manufacturers and vaccine administrators. Claims generally must first be filed in the VICP before individuals are able to seek civil remedies external to the VICP. The National Vaccine Injury Compensation Program, or VICP, has three main players. We have HRSA, the Department of Justice, or the DOJ, and the U.S. Court of Federal Claims, specifically the Office of Special Masters. Within HRSA, the Division of Injury Compensation Programs administers the program and develops recommendations to DOJ, who, based on the medical review of the evidence, they represent the secretary in the proceedings when an individual files a petition alleging injury from a vaccine. The Department of Justice represents Health and Human Services in a court proceeding. And the special masters within the U.S. Court of Federal Claims decides on entitlement to compensation and damages. So as you can see, the three players make up the full VICP program. Anyone who received a vaccine covered by the VICP and is thought to be injured by the vaccine may file a petition, as well as a parent or legal guardian of a child or disabled adult, or legal representative of the estate of a deceased person who received a vaccine. Covered vaccines within the VICP are listed here. As you can see, they range from diphtheria, tetanus, and pertussis vaccines to rotavirus vaccines, polio, a number of things. To be a covered vaccine within the VICP, it must be recommended by the Centers for Disease Control and Prevention for routine use in children and or in pregnant women, and subject to an excise tax. The process for filing a petition or a claim within the VICP, a petitioner files a claim in the supporting documents with the court and HHS. HHS reviews and sends recommendations based on the medical merits of the claim to the Department of Justice, and the DOJ conveys the HHS Secretary's position to the U.S. Court of Federal Claims, and then the court issues the final decision. Over the last 12 fiscal years, you can see here the trend for VICP petitions filed for adults and children. The dark blue line on top, as you see, is the total number of petitions. The light blue line just underneath it are those filed for adults. And the maroon line represents those claims and petitions filed for children. As you can see, claims for adults far exceed those of claims for children. Additionally, in fiscal year 2021, there was a fairly large spike in petitions that were filed, and this was based on the claims of where shoulder injuries related to vaccine administration were going to be, SERVA was going to be pulled from the vaccine injury table, which I'll speak to in a bit. That notice of removal led to a bolus of claims being filed with the VICP. That removal from the table was then later rescinded, and so the program still receives SERVA claims because SERVA is still on the table. But there was, as you can see, about 800 additional claims during that fiscal year that were filed based on the large bolus of SERVA claims. Individuals are able to receive reasonable unreimbursed medical expenses, lost earnings, pain and suffering up to $250,000 in the VICP, as well as a death benefit. The attorney's fees and costs are also covered for the VICP. This includes whether a case is dismissed or not, as long as the claim is brought in good faith by the attorneys. To be compensated, one must demonstrate one of the following. So proof of an injury on a vaccine injury table, proof of causation, and proof of significant aggravation unless an alternative cause unrelated to the vaccine is found. The standard of proof in the VICP, sorry for this timer advancing it. Standard of proof for the VICP is the preponderance of evidence, or more likely than not, as we call it, 50% or end of feather. If it is more likely than not, thus the claim would be awarded to the petitioner. The effects of injury must last greater than 6 months or have resulted in inpatient hospitalization and surgical intervention, or have resulted in a death. For recent VICP trends, 92% of petitions were filed for adults in the last 2 fiscal years. About 74% of petitions filed in that time allege an injury from the influenza vaccine, and over 63% of petitions filed in the last 2 fiscal years allege SERVA as the injury. Now, SERVA is a broad term. I'm sure many of you know of it. That encompasses shoulder pain and limited range of motion occurring after the administration of a vaccine intended for intramuscular administration in the upper arm. I'd like to shift now to talk a bit about the CICP and the PrEP Act. Though these programs are but one letter off in their acronyms and are run by the same division, they are vastly different. As you picked up from the VICP, it is a medico-legal program, whereas the CICP is an administrative program. So the PrEP Act authorizes the Secretary of Health and Human Services to issue PrEP Act declarations. And those declarations provide immunity from liability for any loss caused, arising out of, relating to, or resulting from administration or use of countermeasures to diseases, threats, and conditions determined in the PrEP Act declaration to constitute a present or credible risk of a future public health emergency. And the PrEP Act authorizes a covered countermeasures process fund, which is the CICP. A countermeasure can be something like a vaccine, or it can be anything used to prevent, treat, mitigate, test for the effects of pandemic, epidemic, or a security threat. So while vaccines that are developed to respond to a pandemic response would fall under that countermeasure, also things like monoclonal antibodies or medications or medical devices or equipment would fall under that as well. The CICP has several covered threats. PrEP Act declarations have been issued for medical countermeasures against the following threats. So COVID-19, as we'll talk a little bit more about in further slides, Marburg virus, Ebola virus, nerve agents and certain insecticides, Zika, pandemic influenza, anthrax, acute radiation syndrome, botulinum toxin, and smallpox and other orthopox viruses, which would include mpox. The PrEP Act allows for compensation for serious physical injuries or deaths directly caused by the administration or use of countermeasures covered by declarations. It provides compensation to eligible individuals who sustain a covered injury. A covered injury means serious injury or death determined by the Secretary to be an injury or death that is the direct result of the administration or use of a covered countermeasure, or an injury meeting the requirements of a covered countermeasure injury table presumed to be directly caused by the administration use of a covered countermeasure, unless a more likely alternative cause is found. To establish a covered injury was sustained as a direct result, the CICP may only make such determinations based on the compelling, reliable, valid medical and scientific evidence. Eligible requesters for the CICP program include injured countermeasure recipients, legal or personal representatives on behalf of an injured countermeasure recipient, survivors of deceased injured countermeasure recipients, or estates of deceased injured countermeasure recipients. For the CICP, an individual submits a request for benefits or RFB package. The package is reviewed by CICP medical staff to determine whether the requester is eligible for program benefits, including whether a covered injury was sustained. If the requester is determined to be eligible, they're asked to submit additional documentation to determine the amount and type of compensation the requester may be entitled to receive. If they're found entitled to program benefits, or if they're found ineligible for program benefits, they're notified in writing, and individuals may submit a request for reconsideration. When a request for reconsideration is received, a qualified panel independent of the program is convened to review the program's determination. The CICP can provide reasonable unreimbursed medical expenses, lost employment income, or a death benefit. You'll note that pain and suffering and attorney fees are not covered by the CICP. And CICP is the payer of last resort. So all other mechanisms must be exhausted before the CICP pays these benefits. Between fiscal year 2010 and 2023, the CICP has seen a total of 11,596 claims. Prior to the COVID-19 pandemic, there were fewer than 500 claims. Now over 95% are COVID-19 related. And the program has made 992 decisions in its existence, 496 of which are COVID-19 related. 54 have been found eligible for compensation, and then 938 have been denied compensation for a variety of reasons. So that includes that requested medical records were not submitted to support their claim of injury, standard of proof was not met, or a covered injury was not sustained. An individual missed the 1-year filing deadline. So individuals are allowed to file a request for benefits within 1 year of the administration or use of a countermeasure, or that it was not a CICP covered product that an individual was alleging. We have quite a few claims that are still pending review or in the review process, just over 10,000. And with that, we are very much looking forward to the work that you all will be doing to review the epidemiological, clinical, and biological evidence regarding the relationship between both intramuscular administration of vaccines and shoulder injuries. As you see, that is a significant portion of those vaccines that we or those petitions that we receive on the in the VICP. And then COVID-19 vaccines and specific adverse events. Your conclusions will help inform injury compensation recommendations and decisions when assessing whether specific adverse events are causally associated with vaccines. And with that, we very much appreciate all the work you all are already doing and will be doing in the time to come. With that, I'd like to turn it over to Dr. Shimabukuro for additional remarks.
Thank you, Dr. Grimes, and I'll be fairly brief. First of all, because I think Dr. Grimes did an excellent job describing the VICP, CICP, and describing the tasks for the review. And secondly, because CDC is primarily serving in a support role to HRSA to support this activity. But I will give you a little bit of background on CDC vaccine safety monitoring and our office, the Immunization Safety Office. So our office is the group at CDC that does post-licensure or post-authorization safety monitoring. So after the process of vaccine development and the phased clinical trials, and then a review by FDA and a regulatory action to authorize or license the vaccine, and the vaccine is being administered out in the community, that's where CDC initiates its work in doing the post-authorization or post-licensure safety monitoring. And our mission is to monitor the safety of vaccines given to children and adults in the United States. And we have several safety monitoring systems that we use to monitor the safety of vaccines. I'll just name a few. One is the Vaccine Adverse Event Reporting System, which is a spontaneous reporting or passive surveillance system that's co-managed by CDC and FDA. Another is the CDC's Vaccine Safety Data Link, which is an electronic health record-based system that we use for surveillance and for research. We have our Clinical Immunization Safety Assessment Project, which does clinical research and also does in-depth clinical case reviews at the request of individual healthcare providers. And then what was new for the COVID-19 vaccination program was a new system called VSafe, which is a smartphone-based monitoring system, which uses electronic surveys to conduct active surveillance, meaning that we reach out and contact individuals and we administer surveys to assess their experiences in a post-vaccination period. For COVID, we also stood up a pregnancy registry to monitor the safety of these vaccines in pregnant women and to assess safety outcomes in children in their infants. One of the main things that we do in our office is provide safety data to federal advisory committees, most often to the Advisory Committee on Immunization Practices, CDC's Vaccine Advisory Committee, but also to the FDA's VRBPAC, to the National Vaccine Advisory Committee, and to the Advisory Commission on Childhood Vaccines, which is HRSA's advisory committee, and CDC is an ex officio on that committee. We very much appreciate your time. We consider the VICP and the CICP to be important components of the National Immunization Program. We very much value your expertise and your independence. We look forward to working with you. Look forward to seeing the results of your findings. In the past, we have worked closely with our colleagues at HRSA to support these kind of reviews and to help review and interpret the findings. And again, appreciate your time and very much look forward to working with you on this review. Thanks.
Well, thank you very much, Dr. Grimes and Dr. Shimabukuro. We're really very, very pleased to have this opportunity to work with you and to provide this review and know how important it is to do this in a very careful and rigorous fashion. We've had the opportunity to discuss the statement of task in closed session prior to this open session, and we have some questions. And so I'd recognize folks who have questions on the committee at this point, if you want to use the raise the hand function. And while we're waiting for people to do that, I'll start with one, and it's a general question. And as you know, the National Academies have provided input to the vaccination programs over the years. And the last significant report we had was in 2012. So we're wondering in general how we can improve on that previous work that the academies have done with respect to vaccines, and specifically how that can be of interest to the functioning of both programs at HRSA and CDC.
Thank you, sir. So I will say that the 2012 report has been something that we look at as truly one of the sentinel works in the field. I mean, it is really, really something we lean heavily on from the HRSA side as we make considerations and determinations of causality as it relates to our program. That report mostly informed vaccines that were relevant to the VICP program. This current charge to the committee will be new in that it will be of particular import to the CICP as well as the VICP. So just by doing the work, you are going to be filling a large a need for us. The causality assessments and the structure that you used in that report were really, really essential for us in being able to make these determinations. And so while I can't speak to specific items of improvement as far as methods or anything like that, I think that just looking deeply into the shoulder injuries piece and giving us some very clear guidance on, well, not guidance, I shouldn't say that, but making assessments based on the different types of shoulder injuries that may be out there. I know that that report was focused a little more on deltoid bursitis, at least how we used it in the program. And so look forward to seeing some more specific injuries as it relates that would fall under that umbrella of SERVA to help us inform our decision making. And I'll turn it over to Dr. Shimabukuro if he has anything else he would like to add.
I really don't have anything specific to add. I will say that working with HRSA to review the findings of the 2012 report and working on recommendations for updates to the injury table was one of the first things I did when I started in vaccine safety. And I was very impressed with the rigor in which that review was conducted. And that is still a reference that I routinely use to this day. It is probably the reference I've used the most in my career in immunization safety, and really think it's a kind of a great blueprint to how to do a very thorough evidence review and come up with recommendations for HRSA. So I don't really have any suggestions for improvement, but I will say that that is an impressive piece of work, and again is even timely today. I guess something that I use probably, you know, I don't want to say on a weekly basis, but certainly I routinely refer to that. In fact, I have it on my shelf right behind me, and I pull that book down a lot and use that in my daily work.
Thank you very much. Let's turn to Dr. Bass.
Yeah, this is actually a similar question, a follow-up to George's question. It looked like from Dr. Grimes, your slides, that you've already addressed upwards of 1,000 COVID-19 vaccine claims over the last year. And I guess from that experience, what kind of information did you feel you needed that we could potentially provide? In other words, there might be an outcome X from vaccine COVID-19 with outcome X. What additional kind of information would be helpful to you in addressing those claims?
Yes, thank you, Dr. Bass. So I'll just clarify that the program in its totality since 2010 has rendered just short of 1,000 decisions. Just short of 500 of those are COVID-19 related. We have been making decisions in the program, and really those determinations have been made based on again, the compelling, reliable, valid medical and scientific evidence. And so having a breadth of scientific and medical literature to support causation assessments is essential for us. And so being able to review the outcomes that we had provided as a blueprint, I think would really help us as we make determinations of whether alleged injuries from countermeasures that were deployed in response could have had direct causation in some circumstances.
Dr. Wallace?
Yes. First of all, thank you both for your work. I appreciate it. I just want to, I have a couple of questions. I just wanted to clarify about exacerbations of disease. So if somebody has a pre-vaccination illness, such as say an autoimmune disease, and there's clinical evidence that that gets worse, is that potential grounds for your group?
Yes, sir. So for the CICP, a covered injury can be an injury or its health complications that is the direct result of the administration or use of a covered countermeasure, which includes serious aggravation caused by a covered countermeasure of a pre-existing condition. So as it relates to the COVID-19 portion of your charge, yes, that's correct. Now, serious significant aggravation is also of relevance to the National Vaccine Injury Compensation Program, or VICP, and that would be potentially a consequence of as you look into the intramuscular vaccines and shoulder injuries.
Secondly, in the list of our in our statement of task, there weren't, to my recollection, any psychiatric illnesses. Do you deal with behavioral psychiatric illnesses as outcomes?
So we have received claims of psychiatric conditions that were alleged as injuries for the CICP or the VICP. We do receive those and consider those if there's for the CICP, if there's direct cause. I will also note that for the serious aggravation or of a serious aggravation of a pre-existing condition, it would still need to equate to what is considered to be a serious injury. And so a serious injury, the severity requirement for the National Vaccine Injury Compensation Program is effects lasting 6 months or greater, inpatient hospitalization and surgical intervention or death. For the CICP, an injury would need to either result in a death or be a warrant hospitalization or lead to significant loss of function or disability per the regulation.
So finally, if you have anything to say about what I would call functional outcomes, potential outcomes of a vaccine, such as pain or movement disorder or things that don't have easy names like Guillain-Barré and so on. Do you see functional claims?
Sorry, I was fighting the mute button. Yes, we see claims that really run a wide spectrum. I mean, we see essentially individuals that can file, they typically can file for whatever injuries they feel would meet the requirements of serious. So we have injuries that are specific to like Guillain-Barré syndrome or thrombosis with thrombocytopenia syndrome is where the individual is alleging. But then we also have a myriad of symptoms where individual allege, and as we review the medical records, we're making determinations on whether the individual had a serious injury that was directly caused by a covered countermeasure.
Thank you.
Dr. Sturgakis?
Thank you very much. Close. So on the statement of task, there's a statement within it about the possibility of adding additional adverse events to the assessments. And I would like to understand better if you could talk a bit about, from your perspective, Dr. Grimes, what is the process that would help the agencies best in terms of deciding which, if any, additional adverse events are added. I'll keep my question general, but I have a specific interest in understanding within pregnancy outcomes. Only one was cited, which was infertility, and I didn't know to what extent there might be interest or need, I should say, for broadening that, or for that matter, the process for adding additional adverse events, if any. And my second question, if I can sneak it in, is for adverse events following immunization, there could be various underlying root causes. Could be the platform, could be the vaccine, could be the administration, could be the quality, and to the extent that there's interest in platform type, there are some vaccines that are not used in the U.S., but may be informative by virtue of what they are and how they're constituted and made. And I just want to also ask you about interest, if any, in broadening the assessment beyond the vaccines that are approved and authorized for use here in the U.S. Thank you so much.
Yes, thank you, sir. So to answer your first question, we look to the committee to if there are specific outcomes in the course of your literature review that you feel should be highlighted or further elucidated, and it fits within your the expertise of the committee, then we would leave it to you to work through that with Ms. Dr. Stratton, because we don't inform the processes or anything like that for the committee. As far as, and can you remind me, sir, what your second question was? Forgive me.
Oh, to what extent, from your perspective, would there be a need to look at the vaccine safety profiles beyond those that are approved here in the U.S.?
Gotcha. Thank you for that question. So I think if it is, so the CICP, as we speak regarding COVID-19 vaccines, the CICP only covers vaccines that were approved or authorized for use in the United States. Now, if there is not enough information, literature to support conclusions, and you felt like there was a platform that was the same corollary, that you had more evidence to support it, and felt that it was a direct corollary, we would leave that to you to make that determination. But as far as the vaccines that we as a program are interested in, it's those that are approved or authorized for use in the United States.
Okay, Dr. John?
Yes, this is not directly related to our commission, and if you are not able to answer it, I will understand that. But a question that's come up a lot from parents to people in our infectious disease group is if and when vaccines that are now fully approved by the FDA for use in the United States, so no longer under emergency use authorization, when the adverse events from that might shift from being under the CICP to being under the VICP. So are you able to provide any information on that?
So for the VICP to cover a vaccine, it needs to be recommended for routine administration to children and or pregnant women. It needs to have an excise tax that is imposed upon it. And that is a legislative effort. And then there needs to be a notice of coverage published in the Federal Register. So once those three things all happen, that is when the VICP would cover COVID-19 vaccines. If those three things were to all happen, that is what would sort of initiate that.
Okay, thank you very much. A couple of, I don't see any other hands right at the moment. Oh, here we go. Dr. Fairweather. If you
Just
would
to follow, thank you. Just to follow up on that question, would you be able to provide for us a list of vaccines that fall under that, that have received all of those three necessities?
All three of the vaccines that have fallen to all three of those are those that are in the that have been covered under the National Vaccine Injury Compensation Program. So those are included on the vaccine injury table. You'll find the vaccines that would meet that qualification.
And we have access to that list.
Thank you.
So could you just say your name and affiliation, because I don't think we had a chance to introduce you before, Dr.
Oh, yes. Sorry for being late. We're putting in a couple of grants, so we was rushed to get here. I'm Delisa Fairweather at Mayo Clinic, a professor in cardiovascular disease with a background in myocarditis and autoimmune disease.
Great, thank you. And the committee, I don't see any other hands right at the moment. The committee had a chance to take a look at the preliminary look at the statement of task in closed session prior to this open session. And a couple of questions were raised. So I think I'll raise those on behalf of the committee. And I'll look to the committee to clarify the questions if I have them wrong. First and foremost, why is anaphylaxis not included as an adverse event?
Thank you. So the list of conditions that we provided were based on claims that had been filed alleging injury, and then also areas where we felt we needed additional information. Now, if the IOM report of 2012 was pretty, gave a very good look at anaphylaxis with a number of other vaccines. So we did not include it on this list. But again, as the committee has expertise, if you are interested in including that in your causality assessments, we are, and you have the expertise to do it, we're happy to see that.
Okay, thank you. I believe in your answer to a previous question, you already indicated that with respect to adverse pregnancy or maternal outcomes, that you look to the committee during its review if it surfaces those issues and has the expertise to address those. Is that correct?
Yes, sir.
And then you also addressed psychiatric adverse events in your previous response as well.
Yes, sir.
So,
we provided a number of conditions that we were a blueprint essentially, and information that we would like on those, of course. But again, we looked at the committee if there are other areas, realizing there's a finite amount of time and resources and all those things. Yes, sir.
Okay, thanks very much. There was a question related to adverse events related to heart outcomes, cardiovascular outcomes, and whether or not you would be looking to us for chronic outcomes of adverse events, say dilated cardiomyopathy versus after myocarditis. Would this be a condition that would be compensated? And I'd look to experts on the committee to make sure I'm framing the question properly.
So the as it relates to the COVID-19 work, the CICP covers an injury or its health complications that is the direct result of the administration or use of a covered countermeasure. So in the event that the committee felt something like dilated cardiomyopathy was a health complication of an injury, that is something that we would potentially cover programmatically.
Okay. Does the program need to know the incidence of these adverse events that we're going to look at?
And sir, just to clarify, do you mean incidence in the epidemiologic sense, incidence versus prevalence?
Yes, I think that's the sense of the question.
I don't believe that we specifically need the incidence of each of these. However, I would say that I would hope that in the totality of a comprehensive review, you guys were covering the full epidemiologic and biological and mechanistic picture, so that we have a clear understanding of direct causation as it relates to vaccines, whether they're intramuscular administration for shoulder pain or shoulder injuries, I should say, or COVID-19 vaccines.
Thank you. There was a question about whether or not we should be looking at specific vaccines, a vaccine by one manufacturer, say, versus another, as opposed to COVID vaccines in general. Does that is that important for us to look at with respect to how the program operates?
So as far as the formulations of vaccines, so we cover the vaccine based on the category that it is. So it would be like COVID-19 vaccines, if that's how it was written into the declaration, or for the ICP, the criteria where that would be enacted. We typically don't look at it specifically by formulation because it's sort of in that category. However, I think COVID-19 vaccines present an interesting picture where we have different platforms of vaccine. So for example, an mRNA vaccine is very different than an adenoviral vector vaccine. And so we would appreciate the committee's consideration in making causal assessments for those types of differences, platform differences more so than manufacturer differences.
Oh, that's helpful, very helpful, thank you. Other questions from the committee? Dr. Bass, you had a question in our closed session about extrapolating from mechanistic studies with an example around Master vaccine. Did you want to ask that question?
Yeah, I mean, I think it really is a follow-up to what we've already discussed, which is looking at vaccinations that are not approved in the United States. So if there were a adenovirus vector vaccine that's approved elsewhere, that we could extrapolate from a similar mechanism of action to potentially to similar vaccines approved in this country. So the question, I guess, was just generally one about extrapolating from information about other vaccines that perhaps are not covered here that might provide indirect evidence about mechanism. And is that something that we should or could include?
Yes, so I think if it's like for the example of adenoviral vector vaccines that may have been used more broadly, now I would ask the committee If the populations were a general comparison group, and felt that it was something that could be added to as far as the research goes, then yes, we would not want to limit you on that front.
Okay, other questions from the committee? Let me ask one further general. Okay, Andy, go ahead.
Yeah, Dr. Grimes, is there anything further from your perspective on the process, either VICP or CICP, that would help the committee? And what I'm thinking about is, your slides were informative, as have been your responses, but with respect to things like when determinations are made, is there a process by which you determine like a root cause? That is there anything about the process itself or the the decision making that happens that might be helpful for us to get a better understanding of? Thank you very much. It's a broad question, but
Yeah.
the more we understand, I think the better we can provide what's needed. Thank you.
Yes, thank you for that question. So for either program, we have medical reviewers, so they are health professionals, physicians, nurse practitioners who review the medical merits of the case and make determinations of whether they feel that an exposure, in this case, a vaccine, caused an outcome. For the VICP, those recommendations are provided to the Department of Justice attorneys who represent the Secretary in those proceedings. For the CICP, those causation analyses or determinations are part of the administrative process, and with them we're looking at severity requirement, we're looking at the time frame by which an individual had signs or symptoms after receipt of a vaccine, those sorts of things. And so really we are reliant on the medical and scientific literature to make these determinations. And we recognize the expertise that NASM, or at the time IOM, brings to the table in reviewing in a very comprehensive manner the scientific and medical literature to support these causation assessments. And so as far as we are concerned, we are not only looking at IOM and NASM reports and those things to provide recommendations or determinations of causality, but we are scanning the broader medical and scientific literature base to support our conclusions. For the VICP, the standard of proof is more likely than not. So the standard of proof is 50% and a feather. For the CICP, there has to be compelling, reliable, valid medical and scientific evidence to support that a covered countermeasure as a direct cause of a serious injury. So there's a bit of a difference in the standard there. I hope that was helpful in answering your question. Sorry.
Thank you. And Dr. Bass?
Yeah, hi. I'm sorry if you said this and I missed it, but just a point of clarification for the definition of these injuries. So 6 months, a serious injury or death. I didn't quite catch whether surgery, let's say somebody had an outpatient surgery but was not hospitalized, would that be considered a part of the definition?
Thank you for that question. So for the VICP, the severity requirement is inpatient hospitalization and surgical intervention, or effects lasting 6 months or greater, or death. So in the event of an inpatient hospitalization, it would be inpatient hospitalization and surgical intervention.
Okay.
And I would just, if you don't mind, Dr. Isham, ask if Dr. Shimabukuro has anything that he would like to add on some of my responses.
I don't have anything to add. Thanks.
Great.
Well, I have one more question for both of you, but I want to make sure the committee has asked all its questions as well. So with respect to the the question prior to this, Andy's question, very, very helpful response, and it's sort of related to that. But it's also related to the comments that you made about the 2012 report that we provided to you. And since you both apparently are users of that report, as well as using other sources of information, as you just indicated, to make sure that you're up to date on these things, do you have a sense of how we might look at the methods that we developed in that report for generating our evidence reviews with respect to adverse events, and how they should be or could be updated, or what if there are any gaps, given the fact that that's now a 10-year-old report and the literature is moving on? Do you have any sense of that with respect to the usefulness of that report relative to what we might provide you in this current work? And I'd ask that of both of you.
So I'll let Tom answer first, and I'll piggyback off him. Tom.
I may have to go back and review the methods a little bit on that report. When I use it, it's usually getting right to the assessments, the assessments. But I'm not able to answer that question right now because I would need to refamiliarize myself with some of the specific methods that they use to come to their conclusions on both the epi and the mechanistic evidence.
Okay, thank you. I'm asking that in the sense of how we might make this work most useful to you. So that's the sense of this question. I would appreciate any further thinking you have on that. So back to you, Dr. Grimes.
Yeah, I would speak similarly to Dr. Shimabukuro. I would have to refresh, and if there's anything that jumps out to us, we're happy to relay that to Dr. Stratton.
Perfect. All right. Well, thank you much. Other comments from the committee or questions? Dr. Bass.
Yeah, just one more, just for clarification, because I know when you're no longer here, we'll come back to the anaphylaxis question. So what I'm hearing, I think, is that there does not have to be on those tables. We do not have to provide every possible scenario on those tables in order for you to find causality. So we are not responsible for the universe of potential adverse effects. We have been tasked with certain ones, and you have said, I think, to paraphrase, that in the case of anaphylaxis, even though COVID-19 vaccination was not included, that you feel comfortable extrapolating from the multiple other vaccinations where that complication or potential adverse effect was addressed. Is that, and the same would go for other potential outcomes that we could come up with?
So Dr. Bass, thank you for that question. So we do not need to see the entire universe of potential conditions in this report for us to ultimately make a determination of causality in the individualized case reviews we do for people. I can say that, whether something is on the vaccine injury table or a countermeasure injury table, that does not preclude an individual from filing a petition for us. So, and just because somebody doesn't see that a potential injury was listed, that doesn't mean they can't file and have a determination made either in the VICP or the CICP. If that answers your question.
I think also, if I recall your answer earlier, you indicated that if the committee itself chooses to include that for good and solid reasons, that we have the add to your response.
Absolutely. Yes.
Dr. Fairweather? You're on mute. You're on mute.
Sorry about that. I think this is very similarly related to what we've been talking about, but it seems like we had it in general discussion previously. And that's if something, I guess, important came up that you might want us to address, or that we discovered something important. I guess in that case, we would definitely have the option to add it. But I just wondered if you had thought about that. I guess you would let us know.
Yes. So as I've said before, we leave it to the committee if there are things that are not on that list or outcomes or conditions that in the course of your reviews are felt very strongly that you would want to provide an opinion of causality on. We would leave that to the committee. And we would just ask that you work through Dr. Stratton to work through your processes. I'm sure Dr. Stratton will simply let us know. And you've heard from us. We are willing to, if you have the expertise on a committee to consider it and provide those recommendations, of course, and realizing it's a finite number of people and finite number of days and hours in a day. So yes, we understand all those things.
Yes, and we certainly understand that we are eager to work closely with Dr. Stratton on these issues. So, Dr. Shimabukuro?
And Dr. Sherman, in thinking about your question, something did come to mind that I just want to mention a bit along the lines of methods. I believe for the 2012 report, the strongest evidence, or at least what the group considered the strongest evidence came from clinical trials or well-designed observational studies. I think one difference for COVID compared to the data that were available back in 2012 is during COVID, we had very accurate and timely information on doses administered. So we had good denominator data that was reported from the states to CDC. And it contained quite a bit of detail, age, sex, things like that. So we were able to, in our system, the vaccine adverse event reporting system, I'm able to calculate reporting rates and able to do things like compare reporting rates to expected background rates, so observed versus expected. So I think for COVID, it was the data from our passive surveillance are unique and different to data that may have been available earlier. We really did not have that type of quality information for the denominator. So just one thing I just want to mention to the group with respect to the evidence base and the quality of evidence.
Thank you very much. Appreciate that comment. Any other questions for our sponsors from the committee? Okay, Dr. John.
This is a very basic one and may be obvious, but as you brought that last point up, Dr. Shimabukuro, I was thinking of this as sort of a search of the literature, but obviously there's a bunch of information that HHS has on these things, and I'm not sure if that's all published or where it is, but will we have that available to us as we do our own search?
So we have made an effort to publish information as quickly as possible, and we actually have an inventory of our publications, and we can certainly point you towards those resources where we've kind of cataloged our published information, and a lot of the information where we wanted to get out get information out quickly was published in the MMWR. There may be some information that's hasn't been published that was presented at meetings of the Advisory Committee on Immunization Practices or other federal advisory committees. That those presentations are available as well. So I think we can assist you in getting access to that information, both the published information and the information which may have been presented but isn't published yet.
Thank you.
And once again, any other questions for our sponsors relative to the statement of task and this presentation and information that we've had today? Well, I suppose it then falls to me to express my gratitude to both of you for providing this very helpful conversation about our statement of task. I also want to convey to you how pleased the committee is and how really privileged we feel to be able to do this work on behalf of these important programs. And I want to thank you for that opportunity. So with that, I think we'll stand adjourned as far as the open session. And given the fact that it's almost 10 past the hour, we should we'll conclude this session at this point, and the committee will reconvene in closed session in just a little more than 15 minutes, say at 25 past the hour. So thank you very much. We stand.